Hi, everyone. I'm Dr. Brian Kaufman, co-founder, executive vice president, and the chief medical officer of CLL Society. And I'm delighted to welcome you to today's virtual event, Playing CLL SLL Chess, Planning Your Therapy Moves. CLL Society is dedicated to delivering the best, credible, up-to-date information that's laser focused on the CLL and SLL community's needs. We work to help educate and empower patients and caregivers. We are joined today by Terry Evans, a longtime friend and a 22-year-old CLL survivor and the director of CLL Society's support network, and Dr. Susan O'Brien, professor of medicine at the University of California, Irvine, and a member of CLL Society's board of directors. Dr. O'Brien is deeply invested in solving the challenges of treating CLL today. We thank both of our speakers for giving so generously their time to share their knowledge and answer your questions. This is a special two-part program because after this virtual event, we have invited our speakers to participate into a deep dive into 5 podcasts, where we will collect 5 of the most important and pressing questions on this topic and do a deeper dive for you. We look forward to sharing this additional resource with you soon. We'd like to thank Beijing, Loxo at Lilly, Bristol Myers Squibb, Genentech, and Janssen for making this event possible through their support. I want to take just a few moments to review some of CLL Society's many free educational resources available to patients and caregivers. I'm going to quickly share a few, and if you have any questions, please reach out to us at support@cllsociety.org. That's support@cllsociety.org. We have over 40 CLL patient and caregiver support groups around the country. We will be launching a new watch and wait specific support group towards the end of 2022. So watch out for information on this and the sign-up form. Our expert access program provides a free telehealth second opinion with a CLL expert physician. To apply, you need to have a CLL or SLL diagnosis and be residing in the United States. That's it. If this is your first virtual event, make sure to check out our website for upcoming events and on-demand programming from past events. As I've mentioned, we recommend signing up for our weekly email for information on webinars, on-demand education, and breaking news related to those with CLL or SLL. I highly recommend that you visit our COVID-19 page on the CLL Society's website for recommendations specific to CLL patients regarding the pandemic, checklists in case of exposure, testing positive, need to quarantine, and much more. Our COVID action plan can be a lifesaver. The Ask the Expert section is a great resource where you can email questions to our resident experts. Questions should be of general interest and not require a long explanation or detailed reviews of medical history. CLL Society conducts patient-centric research to help elevate the patient's voice for hematologists and oncologists, as well as general society and the pharmaceutical industry. Lastly, I wanted to mention our Test Before Treat campaign. Please make sure you are getting the right predictive and prognostic testing before your first and every subsequent treatment. Dr. O'Brien will be briefly addressing this important topic, and you can find more on our website under Test Before Treat.
Well, thank you for joining us today. And I am Terry Evans, and I am a 22-year CLL patient and advocate. I want to first tell you a little bit about myself and my journey. I was diagnosed in 2000 by a routine blood test at an annual physical. Actually, my white count was in normal range at that time, but it had been slightly increasing every year. So my primary care physician sent me to a hematologist, and they ran a flow cytometry and confirmed that I had very early stage CLL. That was a complete shock to me because in that same appointment, he told me that it was an incurable leukemia and we were just going to watch it. So here I am being told that I have cancer, but we're not going to do anything about it, which is really uh, quite a lot to absorb. And you think to yourself, well, no, cancer, you have to do something about it right now. And unfortunately, you don't sometimes with CLL. So I was monitored by this local hematologist for the next 7 years. And I was in watch and wait, or watch and worry, as some people call it. I had no treatment at all during that time. But then, unfortunately, my white count went from 280,000 to 540,000 in 2 months. So in October of 2007, I began treatment. I was really given no choice. There was only one option that was presented to me, and I went in for an appointment on Tuesday, and on Thursday he said we're going to start treatment this week. The treatment was really not explained to me. I knew what it was. I knew he told me what drugs were being used, but I really didn't have any understanding of what kind of time it was going to take or how it was going to work. And I wound up only getting FCR, which is chemotherapy, for 3 days. But in that time, I developed autoimmune hemolytic anemia, where your body attacks its own red blood cells. And then I realized I had to make some type of change in my whole strategy for dealing with CLL. I had always intended to see a CLL specialist, and my wife had always told me, let's go make an appointment, but I had put it off. Um, I was doing okay for 7 years and didn't really, think I wanted to go see another doctor. But now, unfortunately, I was in a critical situation where my local hematologist refused to accept the fact that I had AIHA. His solution was to transfuse me, but that really didn't solve the problem. My wife took charge because I was really not in a position to make many decisions at that time. I was really almost critically ill. And so she contacted by email a doctor in England who was very big on some of the CLL forums at that time by the name of Dr. Terry Hamlin. And he confirmed just via an email that I probably had AIHA and I needed to get to see a CLL specialist immediately. So she then contacted UCSD, faxed all my blood tests down there, and I got an appointment within 5 days with Dr. Tom Kipps at UCSD. And as most of you know, getting in to see a specialist is usually, 2 months out, 3 months out. Well, they were concerned enough that they wanted to see me immediately. At that point in time, I had what I call my epiphany. I almost died. I had not done much at all to educate myself. I had not seen a specialist. And I also needed to find other people with CLL. During that 7-year period, I didn't know one person with CLL. And looking back, it was really a pretty lonely time. I had no one to talk to about my disease. I didn't know much about my disease. And I was in a critical place in my journey right then. So I began educating myself, joining more online forums and reading CLL papers online that were from conferences and going actually to live conferences to try to educate myself. And that really changed my whole focus. Where before my wife had been the major one looking into things about CLL, I then became part of the decision-making team. And I went and got second and third opinions from other CLL experts about my particular situation. In 2008, I began participating in a group of CLL patients, which would then become the start of the CLL Society. I'm fortunate now to lead the original CLL Society Orange County, California support group. And I've also participated in starting the other 40 plus CLL Society support groups in the United States and Canada. I've had 7 treatments in my 22 years with CLL. During that time, I've had to do a lot of research to figure out what was going to happen next. I needed to plan for how the next therapy might actually influence future therapy options or what the sequencing should be. This really became real for me when I was on a BTK inhibitor and I became resistant to it. So what that meant was that it didn't matter what type of BTK came down next. If it was of this class of BTK, that I couldn't take it. So I had to actually start looking at other treatment options. Since that time, I've always used shared decision-making with my medical team. I've actually been on 3 clinical trials, mainly because the options to me became even more and more limited based on the number and types of treatments that I had. I've actually had to make some really hard decisions based on the best information that I can gather. And a lot of times that information was incomplete. It was data from clinical trial phase 1. And they said, we think this is going to work, but we're not sure. And so these were really hard decisions that I had to make over time with really not a lot of information. So I want to tell you what I learned from this part of my journey. You really need to educate yourself. You need to go to medically vetted websites. You need to learn as much as you can about your disease, especially before your first treatment. You need to know what are the options in your first treatment, and if you do one, then what will happen for a possible second one. I highly recommend that you join a support group, because this is where you can find other patients and caregivers that are on the same journey as you are, and you can learn from their experience and the treatments that they've had. This is probably my #1 item, is get a CLL expert on your team. This does not have to be your primary CLL doctor, but when it comes time for treatment, it would be nice to run it by somebody and make sure that, yes, it's time for treatment, and yes, this looks like a good option for treatment for you. Or if, like in my case, I ran into trouble, my local medical team didn't know what to do with me, unfortunately, but when I saw the expert, they had seen patients exactly in the same position I was, knew how to treat those patients, and actually put me on a path so they could then treat my CLL. You need to be part of the decision-making team. When you go to your doctor's appointments, you need to make sure you ask questions. And if you're like me, I like to write my questions down beforehand and address those important ones at the very beginning of the appointment. Have someone with you to take notes or record your appointments. You don't want to be sitting there taking notes while the doctor is talking to you, because you'll typically miss something. So recording your appointments or having somebody with you to actually take notes is really a good idea. Another thing that comes up in talking to patients is you just don't click with your doctor. For some reason, you just don't get along. It doesn't feel like they're really answering your questions, or there's something about them that makes you, just feel like you need a change. Don't hesitate to change doctors. Don't hesitate to get a second opinion. Most doctors have pretty thick skins and understand that there are maybe some people out there that know maybe more than they do. And so, yes, get a second opinion. And if you find a treatment that you think might fit you, but it isn't offered at the medical center where you're at, reach out to other medical centers and see if maybe they have a trial closer to you or treatment closer to you that you could participate in. So it doesn't always work out that you're going to get treatment where you go for your regular appointments. You may have to actually go someplace else for a treatment that really fits your situation. So I want to make this very clear. I have almost all of the bad markers. I'm 17p, TP53, 11q, complex karyotype, unmutated, ZAP70 positive. So don't read the things on the internet said that, oh, if you have these markers, this is horrible. You're not going to live very long. You're going to relapse very quickly. This is all data that, number one, it's old data, a lot of it, and make sure that the data that you're reading is current. But here I am 22 years later, and all because of the advances in the treatments of CLL. And a lot of people go many years, even with some of these markers, without treatment, or they get a good remission and it lasts for years and years. At the end, I'd like to thank my wife, who probably, saved my life by intervening, all of my medical teams who actually did save my life, my friends and fellow CLL patients, the CLL Society for making me part of a group of people that really are helping other CLL patients, and the pharmaceutical companies for saving my life. So remember, don't be complacent in this. Remember that CLL is largely an incurable disease. And even though you may be doing well on a treatment or you're having a lengthy remission, there is a chance you will relapse. But be ready for that change by looking into treatments that you would qualify for before you actually relapse. Talk about this to with your doctor, your medical team, about, well, what happens next if I do relapse? And let them give you options as well. Think about your next move when you're planning your present move. Don't be afraid to consider clinical trials. I've been on 3. I basically think that they probably saved my life. And it is the only way we're going to advance the treatment of CLL and hopefully someday find a cure for it. Also, don't be afraid to consult with other medical centers and other doctors for your next treatments, because they may not be offered at the place that you're currently going. I want to end by talking about innovation and intervention. I think we're all aware of the great strides that have been made in CLL in the last 10 years. They are truly amazing non-chemotherapy options that really are giving patients long and healthy lives. But sometimes you need intervention. And in my case, I was in a clinical trial where there was no crossover. A group of dedicated CLL doctors lobbied for a change to be made to this trial so it would allow the patients, of which there were about 197 of us in this trial, that could not cross over. And so there was an editorial written in ASCO Post by Dr. Susan O'Brien, who said, and I quote, "Here's the harsh reality. There are people on the control arm of the RESONATE trial who will probably have disease progression and die." Soon after that, the trial was modified to include a crossover, and that actually saved my life. And with that, it's a pretty good segue to someone that I really admire and thank tremendously, Dr. Susan O'Brien. Thank you.
Hi, everyone. I'm Susan O'Brien, and I'm a professor of medicine in the Division of Hematology Oncology at the University of California at Irvine. And I'm going to talk today about therapy sequence for CLL or SLL. So chronic lymphocytic leukemia or small lymphocytic lymphoma, which is essentially the same disease without blood involvement, is the most common leukemia in the Western world. There are about 20,000 US cases annually, and it makes up 30% of adult leukemias. The median age at diagnosis is 70, so this is a disease of older patients. And importantly, most physicians in private practice will have some patients with CLL because of the leukemias, it's the most common, but they're unlikely to have treated more than a handful. And that's because people in private practice are seeing a variety of cancers, and ones that are much more common than CLL would be breast cancer, lung cancer, colon cancer, et cetera. And so CLL generally makes up a very small part of the practice. And really the only way you can see a specialist or get a second opinion from a specialist is to be seen at an academic center. Well, how do we make the diagnosis of CLL? It's actually pretty straightforward. Usually a person has a blood test done, which can be done incidentally, let's say for a pre-op, maybe to have a knee replacement, or maybe just a routine physical, and they're found to have an elevated lymphocyte count. Note that I have bone marrow exam question mark there. CLL is actually one of the few leukemias where we don't necessarily need to do a bone marrow. And that's because we can do immunophenotyping or flow cytometry right on the cells in the peripheral blood. Since they're right there in the blood, they're easy to access. And flow cytometry is just looking for certain proteins on the surface of the cell. And that differentiates the malignant CLL cell from a normal cell because they look pretty normal, but they're obviously not. And so flow cytometry on the peripheral blood can pretty much tell us, oh, this is CLL. So in most cases, you're not going to need a bone marrow. I won't say that's always the case. Sometimes there are reasons why we do need to do a bone marrow, but if your physician recommends a bone marrow, you might want to ask them why do they think that's necessary. And then we can check immunoglobulins, but that is optional and is more relevant in patients who are having repeated infections where they might need immunoglobulin replacement. So those are the tests that make the diagnosis, but as many of you know, there are tests that help us for treatment planning because they are prognostic tests. And we know that some therapies may not work well for some people who have certain chromosome abnormalities versus other people, et cetera. So FISH is just looking at certain chromosome abnormalities that can occur in CLL. Karyotyping is looking at all of the chromosomes. FISH is usually limited to the 4 most common abnormalities that we see in CLL. We want to look for a p53 mutation because in patients who have p53 mutations, they should never ever receive chemoimmunotherapy, which might be considered as a first-line option. Beta-2 microglobulin is helpful. And then hepatitis B testing is very important because quiescent hepatitis B can be reactivated by CLL therapy. So as many of you know, our standard approach to most patients is watch and wait, or some people like to refer to it, watch and worry. Why don't we treat CLL at diagnosis? Well, it's a very slowly progressing disease in most cases. Many people have no symptoms, as I said, routine physical, pre-op visits, that kind of thing is a very common way that CLL is diagnosed. People are older, so they might not tolerate all the treatments as well, and they also have what we call comorbidities that can make treatment complicated, like high blood pressure, coronary artery disease, renal dysfunction, et cetera. And then most therapies are what we call palliative, in other words, non-curative. They're not curing people. Now, somebody who's outside the CLL world could say, what's wrong with these CLL physicians? Why do they wait for the patients to have more advanced disease and treat them and then say, well, in many cases, I can't cure them? Wouldn't they be better off treating them early? Well, there were a number of randomized trials done in the 80s. And to explain that, a randomized trial meaning half the patients are randomly assigned to one intervention versus the other, and half were assigned to watch and wait, and half were assigned to treatments with chlorambucil. And there was no difference in long-term survival. So that's what led people to say, don't treat early. But obviously, one thing anybody can tell me nowadays is, wow, don't you think we have a lot better therapy than cell? And we certainly do. So there is a very important trial which is trying to address this question: is watch and wait still the best strategy? And that's the SWOG trial, which is now an intergroup trial, meaning it's being done all across the United States. We have it at UCI, but many other centers have it too. And it's a randomized phase 3 study of early intervention with venetoclax and obinutuzumab versus delayed therapy with the same regimen. So in other words, patients are going to be randomly assigned to immediate treatment or to watch and wait, and then just get treated with the same therapy as the immediate treatment later on when they need therapy. But this is not for all comers. The whole idea here is some people will never need treatment for CLL. So what we would like to target are the high-risk patients, where I might see that patient in the clinic and they don't need treatment today, but it's not a question of will they ever need treatment. It's just a question of exactly when. And there are a number of characteristics that can define high risk. I won't go into them here, but 17p deletion, for example, p53 mutations, complex chromosome patterns, and there are a number of things that are assessed in this study. And then only patients who are considered high risk or very high risk by that scoring system, which is called CLL-IPI, can be randomized, and it's 2-to-1. So about 2/3 people will be randomized to early intervention and 1/3 to watch and wait and then delayed intervention. And the other important point to note is that you have to be within 1 year of diagnosis. So some of you that might be on watch and wait and have been there 2 or 3 years, it's too late to enroll in this study. The other very attractive thing I wanted to mention about this clinical trial is that both the venetoclax and the obinutuzumab are completely free. So there's no cost for the drugs. And as many of you know, with oral cancer drugs, we're often concerned with copays. Here, the drugs are provided completely free. And that's true not only for the group randomized to earlier treatment, but to the group randomized to delayed treatment. So even if you don't need treatment for 3 years, if you're on this study, you will still get your drugs provided free later on. So a very, very important study that we're all going to be very interested in knowing outcomes from. But let's talk about our frontline therapy options. What are the things we take into consideration? Well, age, the stage of CLL, person's overall health, as I said, their comorbidities, what are the other problems they have, high blood pressure, renal insufficiency, maybe kidney dysfunction might make us prefer one treatment over another, for example. Of course, the person's own preference, their physical exam, and importantly, the lab tests. And frontline therapies don't have to be the same for every patient, and often are not. But it's also important to know that frontline therapy may influence choices later, and we'll talk a little bit about that. So again, I want to mention clinical trials. Clinical trials are basically carefully controlled research studies conducted by doctors to any or all of the below: improve treatment options, increase survival, or improve quality of life. And clinical trials are always an option. Some people have the mistaken idea that you only consider a clinical trial if you've run out of standard options. That is absolutely not true. And in fact, you just saw that early intervention trial, which is an important one. So you don't necessarily wait for standard treatment to fail to ask about trials. They're not only for people with advanced disease. Again, the trial I just showed you is a very good example of that. In fact, that's for people with early disease. And our clinical trials are the only way that we get new drugs. There's no drug that's been approved for CLL that wasn't previously tested in a clinical trial. And another potential advantage of a clinical trial, and I'll give you an example, is when we were first investigating ibrutinib years ago before it was FDA approved, that meant anybody that went on the clinical trial actually had access to ibrutinib before the general population at large. And I'm sure all of you or many of you know what a blockbuster drug that has been in the treatment of CLL. Just a couple of things to say that because you may see these phrases talked about a lot when we compare clinical trial data. Progression-free survival, and that's kind of exactly what it sounds like. That's something we look at after treatment, and it says, what percentage of the patients are still alive and have not had progressive disease? So kind of showing how long patients are staying in remission. Overall survival shows how many patients are alive, whether they're in remission or not, and overall survival is measured from the start of therapy. So how does ibrutinib, talking about ibrutinib, the first small molecule therapy that we had, square up against effective chemoimmunotherapy? The original comparisons were to chlorambucil, which is a weak chemotherapy that we do sometimes use in elderly or frail patients, but our better chemoimmunotherapy regimens are BR or bendamustine rituximab or FCR. And this is data from 2 different trials. And let me just kind of walk you through this. If we look at the left-hand panel, this was a randomized trial which had 3 arms, ibrutinib combined with rituximab or BR. And what you can see is that the progression-free survival always starts at 100% because you're looking at everybody who's in remission after they get the therapy or during the therapy. And then what makes that curve fall down is if someone's disease comes back or if they die, then the curve will drop. So important things to notice is with almost 5 years of follow-up, you can see that the majority of patients who got I or IR were in remission. And obviously that's a better curve than the BR curve. So those remissions are lasting longer than with BR chemoimmunotherapy. The other important point is adding rituximab to ibrutinib did not seem to offer any benefit because you can see that those red and blue curves are superimposable. What we see on the right, and this was just a 2-arm trial of ibrutinib rituximab versus FCR, is that the red curve, which is again the ibrutinib-based curve, is significantly higher than the FCR curve. So ibrutinib provides better outcomes in terms of staying in remission longer than either BR or FCR. But there's something very important to know about FCR and why we might still consider it as a frontline therapy. This is long-term published data from the MD Anderson, looking at patients. All of these patients received FCR, but the ones shown on the red curve are those who had a mutated immunoglobulin gene versus an unmutated gene. The important thing to notice is that at about 11 to 16 years, the curve stops dropping. So what does that mean? Nobody seems to be recurring after that. And this is really important because then what the suggestion is that there is a cure fraction with FCR. People relapse for a while and then they stop relapsing and they're cured. However, this is a limited population because it's limited to younger patients because older patients don't really tolerate FCR. And it's limited to those who have a mutated immunoglobulin gene. And as I showed you from that curve, it was about 50% of those patients with the mutated gene. So that is sometimes why FCR is still a reasonable thing to discuss as frontline therapy because of this potential for very long-term remission. Now, do we know that with ibrutinib, we won't have people who are in remission 10 to 20 years later? We don't actually know that. Maybe we will. Obviously, the problem is we don't have that kind of follow-up yet for ibrutinib. The longest follow-up we have now is about 8 years, but certainly not anything like 15 or 20 years like we see with FCR. Well, some of you know we also have acalabrutinib, and this shows you the trial that led to the approval of acalabrutinib as frontline therapy. And that was a randomization compared to chlorambucil and obinutuzumab. And in this trial, there were also 2 arms, acalabrutinib alone or acalabrutinib with obinutuzumab, which is a more modern antibody than rituximab and is given intravenously versus the small molecules, which are given orally. And you can see that either curve produced significantly longer remissions than a chlorambucil-based therapy. And then, of course, we have another option, which is venetoclax. So 3 small molecules that are approved frontline, ibrutinib, acalabrutinib, venetoclax, and we're soon to have zanubrutinib. It's not FDA approved for CLL yet, but it's coming based on randomized trials. Here's the venetoclax data. Now, one important distinction on this trial is on the trials I showed you for ibrutinib and acalabrutinib, those drugs are given indefinitely. The antibody is stopped after a few months, but those drugs are given indefinitely. So once you commence on ibrutinib or acalabrutinib, you just keep taking it. This trial was designed rather differently. Venetoclax and obinutuzumab was the combination, and you can obinutuzumab was given for 6 months, and then venetoclax was continued for 12 months, but then stopped. So this is what we call finite therapy, and you can see that vertical line showing you where everybody stopped therapy at that point in time. So here we still don't have a median progression-free survival, meaning more than 50% of people are still in remission. And at 5 years, the 62% of patients who got treated with venetoclax and obinutuzumab are still in remission, but that means 4 years off therapy. So one of the things we need to know when we use venetoclax is that because when people recur, when the disease recurs, they're not actually on venetoclax, we might be able to go back and use it again, which gives us even more options the second time around. So here are our frontline therapy options: ibrutinib, acalabrutinib, and obinutuzumab, venetoclax and obinutuzumab, which doesn't quite look like it's doing as well as the others, but it's 80% in the mutated population. Zanubrutinib is too new. We don't have 5-year data. And FCR is obviously great, but very much confined to patients who have a mutated IGHV gene. By the way, bendamustine rituximab does not appear to have a cure fraction. So if we are seriously considering chemoimmunotherapy because of that possibility, the only one we're talking about is FCR. So just some things to consider with a BTK inhibitor versus venetoclax and obinutuzumab. If we don't use antibody with the BTK inhibitors, they're really convenient because you don't have to come in for monitoring for tumor lysis. You don't have to come in for IV infusions. You're just taking a pill. There's longer term data for those drugs because they were approved before venetoclax. Ibrutinib has been compared to FCR and BR, as I showed you. Acalabrutinib has not, but you saw the data for ibrutinib. So pretty good chemoimmunotherapy. And there's more data for patients going on to receive venetoclax as second-line therapy than the reverse. And why is that? Only because, again, the BTK inhibitors were available on the market before venetoclax. But there's also some advantages to venetoclax. It's time-limited therapy, which is very attractive for people. There's no known cardiac or bleeding risks, so atrial fibrillation or hypertension or bleeding like we sometimes see with the BTK inhibitors. We're not so concerned for long-term adherence because people only have to stay on it for a year, and then obviously the potential for cost savings. So various things to consider. Let's talk about second-line therapy. Again, we take into consideration the same types of things we took into consideration with first-line therapy, but we also take into consideration what did we do the first time around and why was the therapy stopped? Was it stopped because people couldn't tolerate it? Was it stopped because the disease came back on the therapy? Or was it stopped as part of a planned finite therapy? It's very important to note that the prognostic test should always be tested again before the next line of therapy. And that's true for second line, third line, it doesn't matter, with one exception. The IGHV mutation status never changes. So if we have that data up front, that never has to be repeated, but we definitely have to look for chromosome abnormalities, which may not be present initially, but could occur when the disease comes back. So we can use a BTK inhibitor with or without antibody. We can use venetoclax and antibody, either obinutuzumab or rituximab. What we call off-label medications, i.e. regimens that are not yet FDA approved. So ibrutinib and venetoclax might be one of those, and always consider a clinical trial. So here's some important points to consider if a BTK inhibitor was the first therapy. If a patient progresses on any of the currently FDA-approved drugs, and zanubrutinib is FDA-approved not for CLL though, for lymphoma, but that means it can be prescribed by a physician. Switching to a different member of the class won't work. This is very important because if your disease starts to come back on ibrutinib, then switching to another drug is not an effective strategy. If the reason that the BTK inhibitor was stopped was intolerance, i.e. too many side effects and the person couldn't tolerate it, then switching to another inhibitor may be a very good strategy. There are new BTK inhibitors in clinical trials. One of them is called pirtobrutinib and one is called nemtabrutinib. Some of you may have heard of it. They do work after ibrutinib, acalabrutinib, or zanubrutinib are not working. So they do work in that setting, but they are not yet FDA approved. So they can only be used on a clinical trial. Venetoclax does work well in people whose disease has come back on a BTK inhibitor. There's really no role for chemoimmunotherapy second line. There's no curing in the second line setting. And again, always remember a clinical trial may be the best choice. What if we use venetoclax up front, venetoclax and obinutuzumab? Well, remember I said you stop after 1 year. So if it takes 3 or 4 years to relapse, we could go back and use it again. So the cells are not necessarily resistant to venetoclax because the person wasn't on that drug when the disease came back. The second line regimen that was approved by the FDA is actually 2 years, but it's also time limited. And in the second line regimen, it was approved with rituximab, but I myself prefer obinutuzumab, and often we can get the insurance approval for obinutuzumab, even though the FDA approved regimen is venetoclax and rituximab. So again, we could repeat venetoclax. We don't have to automatically go to a BTK inhibitor for second line therapy if we use venetoclax up front. There's less data, but now emerging data that if we want to switch to a BTK inhibitor, it works very well in the setting post venetoclax. Again, no role for chemoimmunotherapy, and always consider a clinical trial. What if chemotherapy was given first? Especially important to recheck prognostic markers. No role for using again. So in the old days, if we got the FCR up front and people recurred, we often gave BR, but there's no reason to do that anymore with the small molecule options that we have. Both venetoclax and a BTK inhibitor work well in people whose disease has come back on chemoimmunotherapy. And just another reminder, always be thinking, would a clinical trial be the best option, and ask your physician what possible available trials there might be. So third and later, we don't have a lot. We have PI3K inhibitors, idelalisib and duvelisib. Again, there's always off-label, meaning not yet FDA approved if insurance will pay for it, and a clinical trial. An important point that you start to hear about now are double exposed or double refractory, and there is a difference. So this is referring to people who've had both a BTK inhibitor and venetoclax. So what might be that distinction? Well, double exposed could be someone who got a BTK inhibitor up front, then their disease recurred while they were taking ibrutinib. Then they got venetoclax-based therapy for a finite period of time. And now a couple of years later, the disease is coming back. So they're exposed to both drugs, but they're not necessarily resistant to venetoclax. They are resistant to the BTK inhibitor if the disease came back while the person is taking it. But remember, with the finite therapy, you can be double exposed, but not double refractory. Double refractory would be people who have actually progressed on a BTK inhibitor and venetoclax. That is starting to be a growing population in CLL, and it's one where it's really the biggest unmet medical need. all the prior points that relate to second-line therapy apply to third-line therapy, fourth-line therapy, et cetera, except certainly as you get further out, they're often not only clinical trials a good choice, they might really be the only choice. PI3K are still an option, but they do have a fair number of toxicities. And there can still be a role for allogeneic transplant, particularly in younger patients, which is a potentially curative therapy. Some of you may be thinking, well, what about CAR Ts? I've heard about CAR Ts. Again, as of now, there is no CAR T that is FDA approved for CLL, but there are a number of CAR T clinical trials ongoing in CLL. We have one open now at UCI, for example, and that could be a great clinical trial option for people who are double refractory. So remember, what therapy you choose first influences what you do later. Progressing after a particular medication doesn't mean it won't work again if you've had a long response after stopping, or maybe if you plan to use it in combination. And clinical trials are often the best choice, even in the frontline setting. So thank you for your attention today.
Thank you, Dr. O'Brien, for your comprehensive presentation on CLL and SLL therapies and the important considerations for therapy sequencing. We're going to begin answering some audience questions and also questions that were submitted to us before the actual event today, and we'll try to get to as many as possible. But if for some reason we're not able to get to your question, please email us at asktheexpert email address after this event, and we will share that email address with you on our closing slide. We also want to remind our audience that we will be creating a deep dive into 5 podcasts covering this topic, and we will be using audience questions and the post-event survey to highlight your most pressing questions for a deeper dive. So tell us what you want to dive into, please. And before we get started with our first question, we had a number of people ask the question in the question box about what is a crossover. I mentioned that in my talk. And in my case, I was on a clinical trial where there were 2 drugs being compared. One happened to be ibrutinib, and the other one was ofatumumab, a monoclonal antibody. And half of us were assigned to one arm, the other half were assigned to the other arm. And the crossover was not allowed if you were on the ofatumumab arm until doctors like Dr. Susan O'Brien, who wrote that wonderful ASCO post editorial, they got together and decided that this was really not even morally right. The response rate on the first trial was approximately 91% on ibrutinib, and so most of us who had been on the control arm, we were people who had had 3-4 treatments. Most of us had really bad markers, so we were a tough group to treat, and there wasn't not a lot out there for us if we could not get the drug. So luckily, the trial was changed, and we were allowed to cross over to ibrutinib after that. So anyway, let's that's the answer to the crossover question. So let's take some questions that were submitted early on. Let's see. This is an interesting one. Can international patients participate in clinical trials in the United States? Dr. Bryan?
Yeah, there's no prohibition against international patients. The issue, of course, is that they have to come to the United States to participate in the trial, which obviously could be a problem depending on where they live. And they also would have to have insurance that would be willing to pay. Now, I have said that usually in clinical trials, the drugs are provided for free if they're investigational, and that's absolutely true. But things that are considered standard of care, so let's say periodic blood counts, which we would be doing for a patient whether they were on a trial or not, right? Because that's how we monitor CLL. Those kind of things are not necessarily covered in the trial if they're standard of what we call standard of care. So insurance would have to pay for those. So those are some of the issues with international participation, the logistics of coming, and then having insurance that will pay for the parts of the trial that are considered standard and not covered by the trial. But there's no prohibition against an international patient participating.
Here's a question about developing a C481S mutation. And is that test ever done before there is a suspected relapse on a BTK inhibitor? Or is it only done after the patient starts to relapse to try to figure out why they might be relapsing?
So it's only looked at. It's only been looked at ahead of time in research. So in other words, there's been some questions asked about, can we identify patients who might have a very small amount of cells that have that mutation up front, and those are the ones who are then more likely to develop as that clone, or as we call it, or that population expands to then they become resistant. The data actually suggests that it's almost never identified up front and probably develops over time. So that was a research question, which I think was a good research question, but in standard practice, there is no reason to do it in someone who's never been exposed to a BTK inhibitor.
Okay. It seems that venetoclax is given as a fixed duration treatment in most cases, but the question is, if venetoclax is working and you are UMRD, what are the reasons why you wouldn't just stay on venetoclax until you do relapse?
So actually, the original FDA approval for venetoclax was as a single agent, meaning not with antibody, and was indefinite therapy. So just like the BTK inhibitors. So that is an option to continue venetoclax indefinitely. And would that ever be done? Well, you raised one issue, Terry, which is, well, what if you're not MRD undetectable? Then the obvious question there is, well, if you stay on venetoclax longer, would you inevitably become undetectable? That is a complicated question, because the simple answer is some people they may become MRD undetectable, but some people never will. In other words, they just have an inherently resistant population of cells that are never going to go away, and they may not become MRD undetectable. So it's a very complicated scenario that I think you would have to discuss with your physician to decide, would it be better for you to continue? There are some people, for example, who feel if patients have high-risk characteristics, and I would say the most common one that we're talking about is a 17p deletion or p53 mutation, that even if they'll never become MRD undetectable, maybe they'll stay in remission longer if they stay in the drug. These are all sort of open research questions, but reasonable questions. And I think it's not unheard of to continue the venetoclax, but I think that that's a pretty complicated bunch of factors there that really would need to be discussed between the patient and their doctor, but it can be done for sure.
Okay. This is an old test that was used quite a bit, the ZAP70 test. Does that currently affect any treatment choice in today's environment?
So when ZAP70 was looked at originally, it was people were looking for surrogates for mutation status. So let me give you a little background there. Mutation status, the IGHV mutation status, was described as being an important prognostic factor well over 20 years ago. Well, how do we get that? We have to what's called sequence the gene. So you have to take part of the CLL cell and look at the amino acid sequence. 20 years ago, that was quite a complicated endeavor, and it was also extremely expensive. So at that time, people said, well, are there tests that would be easier to use that might be surrogates. In other words, if you're IGHV unmutated, then you're ZAP70 positive and vice versa. So they started looking for them. Well, two important points to make is there's really no surrogate, because although ZAP70 status does correlate with mutation status, and again, patients who are unmutated tend to be the ones who express ZAP70, so that's a more high-risk population, but they don't go together about 25% of the time. So yes, there's a correlation, but it's not like 98% or 99%. The second important point is that over 20 years, sequencing or establishing the mutation status has become really pretty easy, rapidly done nowadays with the current sequencing techniques, not terribly expensive. So there's sort of no reason to look for surrogates as there might have been 20 years ago. So in general, we don't use ZAP70 nowadays, because the real interest, as I said, was a surrogate for mutation status, and now we can get mutation status pretty easily.
Okay, here's one. If progression happens after remission from venetoclax and obinutuzumab, would venetoclax then be tried as a monotherapy again indefinitely, or would you go back to a combination therapy of V/O? And would there be a fixed duration due to UMRD?
Right, so I think that there would be three options. Well, there are more than three in that setting. There's three venetoclax options. There is also the BTK option, as we talked about. So the three venetoclax options are the FDA-approved regimen, which, as I mentioned, is venetoclax and rituximab given for 2 years. And the idea is now, when you're using it up front, 1 year is probably enough. But now if the disease has come back, it's a little bit more resistant, right? Because whatever disease has come back kind of escaped the frontline treatment, and we're able to survive and then recur later. So inherently, the disease is a little more resistant, and maybe we need to go for a longer period of time, which I think is reasonable. So at that point, if you were going to use venetoclax rituximab, the FDA-approved regimen, it would be 2 years and stop. As I mentioned during the talk, because I think obinutuzumab is a more potent antibody, I personally rather use obinutuzumab again, even if I used it up front. And again, as long as insurance will pay for it, in many instances, you can do that, although I probably would go with the venetoclax for 2 years in that setting, but just switching out the antibody. And the third option that you also mentioned, Terry, is just using single agent venetoclax indefinitely, as it was originally approved. Again, my preference would probably be based on how long the remission was. And so let me just say right up front, there's no simple answer to, well, how long a remission, if you use obinutuzumab up front, is a long enough remission to go back and use it again. Well, I mean, some of it's intuitive. If you stop therapy, so we know that at 5 years now, about 60% of people are still in remission. And I mentioned that in the talk. So if you're a patient whose disease comes back after 1 year, your disease is not very good, obviously, because you had a really short remission when, the average person is going for years. Well, that's probably somebody that I would be disinclined to use venetoclax again. But there's honestly very few patients like that. It's very unusual to see a very short remission like that, but it can happen. On the flip side, let's say that the person's now 4 or 5 years out from having therapy. To me, that's a really long time. And so that's a patient I would be very comfortable in going back and using the regimen again. And then obviously there's a gray area where physicians might agree or disagree. Is 2 years long enough? Is 3 years kind of the cut point? I wouldn't say that's very well established yet in terms of, do all experts do the same thing? And as is often the case, the reason that things are not well established is that there's not a lot of data. So if now the latest, most updated data that we have for venetoclax and obinutuzumab is 5 years, and as I mentioned, we don't have 10-year data, it's a little hard to say, well, what's a good length of time and what's a poor length of time until you get further out and you can look back retrospectively and things become a lot clearer. But certainly I'd say a year remission would be bad. No, I don't want to go back to the same regimen. 4 years would be good. And then again, the between is a gray area and would certainly necessitate a discussion with the patient and their physician.
Okay, there's several questions about people already had FCR treatment and they stopped either because they were doing well or they, in one case, had neutropenia. But then several years after completion, they needed another treatment. But does the fact that they were on chemotherapy preclude any of the use of the new regimens that are out there?
Not at all. Any of them would be perfectly good choice.
Okay.
But I would remind people that they need to check their prognostic factors again, because that might influence the choice of the small molecules.
Right. Let's see. Somebody wanted a definition of TP53. So maybe quickly just
Sure.
describe that.
So, right. So why do we lump sort of patients who have deletion of 17p? And I think everybody understands what that means. But just to clarify, I'll just remind you that every chromosome has two arms, a long arm and a short arm. And the long arm is called the Q arm and the short arm is called the P arm. So in patients with a 17p deletion, they're actually missing part of 17p. It's gone. Well, one of the very important proteins that's on that missing segment, and so now that person is missing that protein, is p53. So in some people, they have the full arm of 17p. However, they still don't have a functional p53 because it's mutated. So it's not missing like it is in a 17p deletion. It's still there, but it's mutated. So either way, because you lose it, you don't have it anymore, it's not functional, or because it's mutated, it's not functional. And so that's why, in essence, having either one of those puts people into a high-risk group. Now, most people actually have both. But you can't, when you detect 17p deletion, if you detect that, do you need to check for the mutation? Not really, because it's the same impact. The flip side is the important side. If we don't detect a 17p mutation, there is a small percentage of people, probably about 5 to 10%, who have a p53 mutation who don't have the deletion. So if you detect the deletion, you're done. You already know you're high risk. But if you don't detect it, you still would want to do the p53 mutation analysis to try and find that 5 or 10% who now, if they have that mutation, are also in a high risk category.
Okay. Here's one on, is there any way to detect what someone is relapsing before it actually would show up as an increase in your ALC or your white count? I know that a lot of places do uh, flow cytometries and they test 1 in 10,000, but there's also 1 in 100,000 and 1 in a million tests. Do you know if many places actually do 1 in a million tests like MRD6 to really get deep and find out if somebody is on the road to relapse?
Well, most of us don't do it standardly, and here's the issue with that. Even when you detect MRD at the more standard assay, Terry, as you said, 10 to the fourth or 1 in 10,000, it's still often a very long time before the disease comes back. And certainly if you detect it at 10 to the 6, we're talking years. So then the important question becomes, well, is it beneficial to intervene or wait for relapse? Well, we don't have any clinical trials that have answered that question. You might say, well, what would be the negative of intervening? Well, especially if you're a relatively young patient, if your disease is not going to come back for 3 or 4 more years, you just bought 3 or 4 years where you don't have disease, you feel fine, and that gives you more time while therapies evolve and potentially gives you an even broader choice of options when the disease actually comes back. And remember that when the disease actually comes back clinically, we still might not want to treat it. So if the first manifestation of recurrence is a lymphocyte count of 10,000, do we need to treat that? No. I mean, we do watch and wait when the disease comes back generally, same as we do up front. And again, what's it doing? It's buying time. And as you buy time, you live longer, and you also potentially have more therapeutic options because treatment is changing all the time. So in general, we are not looking consistently at MRD because frankly, we don't know what to do with that information because we have no clinical trial data that has said, oh yeah, the outcomes will be much better for people if you treat them only when they're MRD detectable rather than when they have disease. And I could make a nice case that they'd be worse because you're gonna use up your therapies too fast.
Right, right. Yeah, you actually answered one of the questions in your answer. If I can find the question, now I can't find the question. Okay. Could you just, I know you did it in your talk, but can you quickly just go over the differences and considerations for choosing one of the BTK inhibitors, including zanubrutinib and also LOXO 305?
So LOXO 305 is not yet FDA approved. So that's
Right.
also known as pirtobrutinib. So that's not an approved drug. So for the options for frontline, the two approved drugs in CLL, FDA approved is what I mean when I say approved, are ibrutinib and acalabrutinib. The data suggests that they're both very effective, but acalabrutinib is less likely to cause atrial fibrillation, which is an irregular heartbeat. On the other hand, if you look at aggregate data for ibrutinib, atrial fibrillation occurs probably about 12% of the time. So the flip side of that is 88% of people are not going to have it. But the incidence is somewhat lower with acalabrutinib. And the incidence of hypertension is also significantly lower with acalabrutinib. The one side effect that is increased is headache, but the headache's usually pretty mild. It happens right at the beginning and very responsive to caffeine, Tylenol, anything, and tends to go away within the first few weeks. So that's one advantage of acalabrutinib. I will also point out that it has to be given twice a day versus once a day with ibrutinib. Zanubrutinib will be FDA approved for CLL soon. Again, many physicians do use it. It is FDA approved, but for lymphoma. And again, that would be considered off-label. Once a drug is FDA approved, a physician can prescribe it for whatever they think fit. So if I want to prescribe it to my patient with CLL right now, I can. The issue is, will insurance pay for it? Sure, I can prescribe it, but excuse me, if insurance is not going to cover it, we can't use it, practically speaking, right? There is also data that zanubrutinib causes less atrial fibrillation than ibrutinib, although the data so far suggests the rates of hypertension are about the same. There is a head-to-head trial of the two drugs in the relapse setting, not up front. So it depends how much we'd be willing to extrapolate from the relapse setting to the frontline setting, where we should find out soon if zanubrutinib is producing longer remissions than ibrutinib. We don't know that yet. So right now, the decisions would be made more on a toxicity basis. And at least from that point of view, the one drug where there's reduced atrial fibrillation and hypertension right now is acalabrutinib. But all of them are great, very effective drugs and reasonable choices.
You mentioned the watch and wait clinical trial. Do you happen to know if that trial is still open or not?
Oh, yes, it will be open for quite a while because it's only enrolling high-risk patients, which are a smaller subset of every newly diagnosed patient. It will take a while for that accrual to be complete. So I think that trial will be open a couple of years, actually.
Okay. This is a question that I also am interested in. If somebody has been treated with the triplet therapy, which is either acalabrutinib or ibrutinib and venetoclax and obinutuzumab, and they're on it for a while, they get to undetectable disease, and then they relapse. How do we know is there a way to tell which drug was the one that was not working that well? Would you put them back on the triplet therapy if they did relapse? Or would you have to do some testing to figure that out?
So I'm not sure I would say that any of the drugs weren't working well, because again, remember that this is finite. All of these combos are finite therapy, generally about a year. So if the disease comes back at 5 years, the whole conversation has been, well, we probably can go back and use the same drugs because
Right.
the patient is not developing resistance while they're taking it. So I'm not sure I would say that any of them aren't working. Um, but if one wasn't and the rest were, there would be no way to know that. But I don't think I would say that about any of them. If you were relapsing while on all three of them, which would be kind of unheard of, then no, there wouldn't be any way to say, well, are you more resistant to one drug than the other? But that doesn't really happen. People respond, they come off, and they relapse somewhere down the line. So that's realistically what we're talking about. So again, I think it's a similar discussion to the one we had about obinutuzumab. If people recur later on, what's a long enough period of time to be in remission to say, oh yeah, that was pretty long, let's go back and use the same regimen again, versus, oh, that was kind of a short remission, maybe I don't want to use that. So I think it's the same kind of conversation. It's just a little bit more complicated by the fact that you could go back and use then an antibody, or you could go back and use BTK inhibitor plus or minus antibody and not do the combination. So but it's a very similar conversation to, do you retreat with obinutuzumab? Do you switch to a BTK inhibitor? It's the same really discussion.
Right. Right. Um, Someone received rituximab for treating AIHA, and does that mean that they are still treatment naive, or does that mean that they've actually had treatment, since it can be used for CLL?
So just in case some people aren't sure what AIHA is, that's hemolytic anemia. So yes, it's a known treatment for hemolytic anemia, and sometimes that's the first problem that happens in a CLL patient that we have to address. And rather than treating the underlying disease, we can just use single agent rituximab, and that often works very well to stop the hemolytic anemia. And then if there's no other indication for therapy besides the anemia, we don't actually have to then treat the patient. So yes, in general, I would consider those patients treatment naive, because all they've had is a relatively weak antibody. They haven't had a BTK inhibitor, they haven't had chemo, they haven't had venetoclax. So I think it's reasonable to consider those patients. Now, that's my interpretation. If the person is asking for a clinical trial, that the eligibility may vary depending on the trial, and they would just have to look at what the trial says as to whether prior antibody therapy counts as treatment.
Okay. Um, let's see here. Let's see. I'm going to go back to the questions that were. This patient was offered 2 clinical trials, one in pirtobrutinib versus ibrutinib, and one of, it looks like VO plus versus acalabrutinib. So I guess, yeah. So it looks like pirtobrutinib versus ibrutinib, or venetoclax and obinutuzumab against acalabrutinib. Some special characters
I'm not
that I can't read.
familiar with that. I see. I'm not familiar with that latter trial. I think both trials would be fine. In other words, this would be frontline, because I'm aware that pirtobrutinib versus ibrutinib is a frontline trial. So I'm assuming this person has never had therapy before. I'm not familiar with that other trial, but as you said, maybe the character issue is not making clear what
Yeah,
that trial is. I think
right.
any trial that is questioning it gives you two good options and is trying to look at which one is better, is a very reasonable trial, because you know that whichever arm you get on, you're going to get an effective therapy. And so then you just have to look at the pros and cons. So for example, if it really was venetoclax obinutuzumab versus acalabrutinib, and again, I'm not familiar with that trial, that would be, I assume, finite therapy versus continuous therapy. So both options are excellent, but the patient might be a patient who says, I don't want to be on continuous therapy. Well, then they don't want to participate in that trial, obviously. But if you don't have any a priori ideas about this is acceptable or this isn't acceptable, then you discuss with the physician, what are the pros and cons of each arm. But I think any trial where you're going to get a good effective therapy up front, no matter what you do, is probably a reasonable clinical trial design.
What about dose holidays? Some people are, asking about, well, can I take a break from my BTK inhibitor? And some even say, can I stop for good? Knowing that, generally BTKs are until you relapse or, you can't tolerate it anymore. But we do have patients that we know in our group who have stopped their ibrutinib and they've been fine for several years. But what about stopping and starting ibrutinib, or even reducing the dose of ibrutinib? Any data on the results of that?
So the first thing when somebody asks me that is, I like to ask them, why do you want to do this? Now, you might be thinking, well, because of side effects. That's if it's because of side effects, then I think one has to look at what the side effects are and decide what the right strategy is. However, I have had people say that to me, and I asked them, and I've said, why do you want to stop when you don't have any side effects? And they've said, well, I just don't want to be on the drug anymore. Okay, fair enough. But then, and I have told patient every time I've started a patient on a BTK inhibitor, I've said, look, if you don't like the idea of indefinite therapy, if you've been in remission, and not for months, because that's too short, but if you've been in remission for a couple of years and you come to me and say, look, I want to stop because, this reminds me, I have leukemia, I'm doing great, I'd rather be off therapy, or the copays are really taxing, whatever the reason is, I said, I'm perfectly happy to have that discussion. And the reason for that is that we know from some clinical trial data that, so in the trial I showed people of ibrutinib rituximab versus FCR, there were patients that came off ibrutinib rituximab at an average of about 1 to 1.5 years on therapy. So they'd been on therapy about 1 to 1.5 years, and they came off because of side effects. Well, the data from that trial suggested, and 1 to 1.5 years is not that long, that those patients had a remission that lasted about another 2 years off BTK inhibitor therapy. And my assumption is if you're on it even longer, say 2 or 3 years, your remission's going to last even longer. Why am I saying that? Because the longer you're on it, the lower the disease burden you have at the time you stop. And the lower the disease burden at the time you stop, the longer it's going to take for the disease to come back. So I have nothing against that strategy. I don't really like holidays. I don't like stopping and starting, because to me, that is a way to develop resistance to the drug. Letting kind of an escape, that time when you're off, an escape mechanism. So if you want to stop for good, I think it's a reasonable discussion. I don't like stopping and starting. What about dose reduction? I have had people say to me, can I dose reduce? There's some preliminary data that probably does no harm in the long run. So if you need to dose reduce for side effects, absolutely. But I have had people say to me, well, I'm not having any side effects, but I just want to dose reduce because it's a cancer drug. I'm not crazy about that rationale. If you're having side effects, yes, absolutely. But I wouldn't say it's a cancer drug like you're taking plutonium. So I'm not really in favor of decreasing if you don't need to, because although the data suggests that you probably will do just as well on a lower dose, there's no randomized clinical trial where, say, people were compared on a lower dose versus a higher dose where we really feel confident it doesn't make any difference. It's just what we call retrospective analysis, kind of looking at the outcomes of people who dose reduced and kind of comparing them to those who didn't and seeing if they do as well. And the suggestion is they do. But again, I think you have to look at the reasons for stopping or dose reducing. But I think either is a reasonable strategy when it's based on clear-cut side effects.
Okay, unfortunately, we had 178, 79 questions, and we could not get to all of them. We're
Yikes.
running out of time. And and we had 30 that were submitted before the session. Please, if you do have a question that didn't get answered, please send your question to the Ask the Expert email that'll be posted. So Dr. O'Brien, do you have any closing thoughts on this topic and session?
It's nobody ever wants to have a cancer or leukemia, God knows. But if you have to have CLL, this is the time to be living with it, because the change in the options are evolving at a dizzying pace. Remember ibrutinib, right, which was kind of the one that broke through, the first small molecule, was only approved about 7-8 years ago. We have ibrutinib, we have the PI3K inhibitors, idelalisib, we have duvelisib, we have obinutuzumab, the antibody, we have venetoclax, we have acalabrutinib, we're about to have zanubrutinib, and we have combinations. That's all in the last 8 years. CAR-Ts are coming, other drugs are coming, the second generation BTK inhibitors like pirtobrutinib are coming. I think that at least it's a disease where we have so many options now that I think you can really take heart that you're gonna, if you have CLL, you're gonna be living for years and years with the current treatment options, and they're only getting better.
Okay, well, thank you very much for that, and thank you for today, spending the time with us. I think there's a lot of unanswered questions that we've still got on the board. So with that, I want to thank the sponsors of this event, and that is Beijing, Bristol Myers Squibb, Janssen, Loxo at Lilly, and Genentech, and they make events like this possible for all the patients that are out there, and really do appreciate their support. I just want to thank all of you for joining us today, and thank you to Dr. O'Brien again for her time and expertise. Please complete the events survey, provide us feedback to help us plan for future events. Somebody mentioned to us that there may be a part 2 to this. The virtual event was recorded, and it will be available on the CLL Society website in approximately a week. And again, if your question was not answered, please send it to Ask the Expert, ASKTHE expert at cllsociety.org. And also join us for the annual Patient and Caregiver Educational Forum in partnership with the Huntsman Cancer Center on November 16th to learn more about CLL basics, diagnoses and testing, the importance of screenings for secondary cancers, vaccinations, treatment options, and more. Also look out for the Deep Dive 5 podcast as an added resource on the topic of therapy sequences. All right, so please remember the CLL Society invested in your long life, and you can invest in the long life of the CLL Society by supporting their work. Thank you again for joining us, and remember, smart patients get smart care.